Assalamu alaikum. Today we are performing a right nephron sparing nephrectomy or a partial nephrectomy for a 3 centimeter lower pole mass, which is mostly exophytic. Here we have performed the mineralization of the colon, and we have dissected the lower pole, identified the ureter, and now we are playing around the pedicle. So according to the principles, we are dissecting the renal vein and the renal artery. Upon the knowledge of the anatomy on the CT scan, we found that the artery is exactly posterior to the renal vein. So this is the renal vein that you can see, and we are trying to dissect out the tissue around the renal vein to find the renal artery. However, we find here that there are dense adhesions posterior to the renal hilum. So the purpose of sharing this video is this is the purpose number one that you can see here now, this one. So there is bleed from the vein. So the first principle is to just apply a pressure. We did not increase the pneumoperitoneum because it's just a small bleed, and it can be controlled by applying the pressure. And while the compression gauze is there, and there is no active bleed, and so we, in the meanwhile, we try to dissect behind the vein. And when we come back to that place again, we found that the bleeding stopped for a while, but it started again. So it means that the hole in the vein is such that that it cannot be stopped by compression or by just increasing the pneumoperitoneum. So the principle is a temporary control and then a definitive control. So the temporary control was achieved, but for the definitive control, we found that the small hole need to be repaired. So we took the Proline 50 round body needle, and we applied a figure of 8 to that hole. You can see here that the hole is there. So figure of 8 has been applied with 50 Proline, and then initial 2 knots, that means the surgical knot is applied, or the surgeon's knot. So this is the definitive management of the renal vein, where we already, whenever we perform partial nephrectomy, whether that is open or laparoscopic, we always take consent for nephrectomy as well. So in the back of my mind, there was this radical nephrectomy, but I said let's try to save the vein. So we applied this 50 suture, and we saw that bleeding stopped, and so a little bit of cleaning was performed, and then 1 or 2 more knots were applied. So after taking a definitive control of the bleed, we started dissecting the posterior aspect of the pedicle so that the renal vein and artery are dissected even more. Complete mobilization of the tissue around the renal pedicle, the artery, and the renal vein is really an important step in performing a partial nephrectomy, because only in that way you can apply the bulldog clamp. And then after dissecting around the renal artery and vein, then is the dissection between the renal artery and the vein by the 5 millimeter right angle forceps. Here a window is created between the renal artery and the vein, and then a 10 millimeter right angle is placed between the artery and the vein, and that small window, by making the window bigger and bigger, slowly and gradually, keeping in view that we must not open any other small holes in the renal vein, or for that matter the artery. So after that we apply the blue vascular loop around the vein, and then we also go for a red vascular loop around the artery. This will also help in application of the bulldog clamps. And then, of course, we try to expose the surface of the tumor. The tumor is lying on a little posterior aspect of the kidney on the lower pole. But strangely enough, there has been a lot of fibrosis on the lateral aspect of the kidney, which really posed us some difficulty. After doing that, we are marking our area of resection. This is really important because once resection is started, it is usually impossible to pay any attention to anything. So it is really very good to mark the area of resection. And then we place 3 vicryl 1 sutures, and then we place the bulldogs in, and then after that we apply the bulldog to the renal artery. Here it is applied, and after that, waiting for a few seconds, then we go for clamping of the renal vein. So after that, the color of the kidney has changed, and now we have started resection. So another important event is occurring here. While the resection, you can see that there is a lot of bleed, and the bleed is also bright red, which means that either we have not completely ligated clamped the artery, or one of the branches may have been missed. So you can see that there is spurt of the blood from the bed. But the principle here is that you should not stop here, and you should not check for any arteries here and there at this moment, as we know that we are not doing a major resection. It's just a 3 centimeter mass, which is purely exophytic. So we can continue cutting, because a small area is only left. Only 50% of the area has already been resected, but a little area is remaining. So we, instead of stopping cutting the tumor, we did not go to the pedicle. So we continued our resection. In the meanwhile, there was a little drop in the blood pressure of the patient, and the anesthetist team was really vigilant to deal with that. But it really helped us. It was a kind of hypotensive anesthesia, so there was a little bleed. So after removing the tumor and taking good resection margins away from the tumor, we found that there is again a dense fibrosis at one end of the resected area, and the capsule there is really very hard, and even the scissor. So after that, the next thing is to do the Renorrhaphy. Here the area is not very deep, so we do not have to really go for inner Renorrhaphy with the vicryl 2.0. So I think it was enough to repair the area or do the Renorrhaphy with vicryl 1. A stratafix or a V-lock suture or a barbed suture can also be used, but that would be more expensive. So the clip is applied on both the sides of the suture so that it doesn't slip away. You can see that there are more bleeders in the lower half of the resected area as against the upper half. So, and that bleeding is now controlled, and we keep on stitching the area, taking deep stitches. So we apply another clip, and that's it. The bleeding is now controlled. As there were areas of strong bleed in the lower half, we decided to go for another layer. So that's another layer of external Renorrhaphy, taking the stitches a little deeper. It's amazing that you do not have to take any knots, just apply the Hem-lock clips. Talking about the costs of the Hem-lock clips and the Stratafix suture, one advantage in Vicryl is that you can use a bigger suture with a bigger needle, so it can go deeper into the renal parenchyma, whereas in the Stratafix or the V-lobe or the barbed suture, the needle would not be that big. And the other thing is that even if you are using 2 packs of the Hem-lock clip, even then it will be more economical as compared to that barbed sutures. Now, with the second layer of this suturing, one can really clearly see that the bleeding is completely stopped. In the meanwhile, we took around 18 to 20 minutes from clamping to resection and then stitching. So after completing the stitching, we will be unclamping the kidney, the pedicle, and we will see if there is any bleed. So we unclamp the artery, and there is no bleed after unclamping the artery. So we cut the loop around the artery and the vein, and then we remove the Hem-lock clips, and we cut all the needles of the suture, and we remove them as well. If there is any gauze, that is removed and replaced with a new one. So a Surgisil is being placed on the bed of the resected area. Another one is placed just to cover the previous one, and also the cut edges of the parenchyma. And then we cover the resected area, the lower pole of the kidney, with the remaining gyrotous fascia, so that the surface of the parenchyma is covered. We resected a lot of area of the renal parenchyma just to get the negative surgical margins. And the problem is that we do not have peroperative laparoscopic ultrasound, so we have to really do our assessments preoperatively, and then also resect areas a little deeper. So after removing all these needles and sutures, we place the specimen in the retrieval bag. And after removal of the specimen, we'll place a drain in the pelvis, clean the area, wash it thoroughly, remove all the clots, and the procedure is thus done. Thank you very much for watching.